كده والله نطبل. اسمع اطفئوا عيد اطفئوا عيد بسرعة بسرعة ببلش من تيك توك.
سيء مش منطقة.
So we will take about 2 minutes finishing up with the second lecture yesterday, which, as I said, it's going to be instead of the 1st of June lecture. So you do not need to come at 8 on Sunday, June 1st. Okay? This is the cover. Okay, so yesterday we just discussed a few things about cough, and as you remember, I told you you have to know 3 main things about cough. Cough is a reflex, cough is a symptom, and cough is not always bad. Right? Now, we always try to treat the dry cough while we just let the productive cough be there, because it's a protective cough and it just cleans your airways and from whatever was inside. Okay? Now, the management of cough, and I haven't said the treatment of cough, management of cough starts always with the treatment of the underlying condition. And as I told you yesterday, the most common cause is respiratory or respiratory infections, whether viral or bacterial. And the second common thing is the allergic reaction. So try to treat the underlying condition, cough will resolve by itself. So if you have upper respiratory tract infection, there's no need to treat cough, because it's going to resolve once the infection is out, right? And if you have allergic reaction, try to target the allergic reaction rather than treating cough as a symptom or as a sign. But nonetheless, we sometimes need to suppress cough because it might be interfering with the normal life, right? When it's dry, it's bothering the patient too much, it's too long for too long time, then you have to suppress it. You have to give him something to feel better. And here comes the few drug options we have for the suppression of cough. Yesterday we discussed that antihistamines could be one of these agents. And as I told you, there is some controversy, because antihistamines as a mechanism of action will not target the cough reflex, right? But we might take it from another point of view. If you are giving an antihistamine to stop the allergic reaction from the beginning, then the stimulation of the cough receptors will be less, right? So that's why antihistamines might be beneficial in some way or another for the suppression of cough, right? But it's not a directly acting anti-cough agent. Okay? Now the 2 drug options we have so far for the suppression of cough are the following. The first one is codeine. Have you heard of this drug? So, what's codeine? Codeine is a naturally occurring opiate, okay? And the prototype opiate is morphine. Actually, codeine is a methylated morphine. Now, when we say something is a derivative or something closely related to morphine, that means within your body, this drug will be metabolized down to morphine, right? Now, this is what happens with codeine. The actions of codeine are mostly derived from its conversion to morphine, except the anti-tussive effect or the anti-cough effect. They're directly related to codeine itself, okay? Now, codeine can be considered as anti-cough medicine by 2 main mechanisms. Now, because it's an opiate, then you would expect that it's centrally acting drug, right? Now, we have the cough symptoms, and as I told you yesterday, nobody knows exactly the location of the cough symptoms. They say it might be within the medulla or the brainstem in general. Now, what codeine does is a direct inhibition of the cough center. That's the first thing, right? It goes into the cough center and inhibits that. So the signaling through the efferent pathways into the airways and into the epiglottis will be suppressed, right? So there would be less cup or no cup. The other thing that codeine does is that it goes into the cup center and it tries to reduce the sensitivity to the afferent signals. As I showed you yesterday, we have here the receptors within the airways, within the lung, within your throat, and these will send signals through the afferent pathways into the cup center. Now, codeine inhibits the cup center itself, so there would be less firing through the afferent. And the other thing is that it inhibits or reduces the sensitivity to signals coming from the afferent pathways. By the way, these are all speculative. They think this is what codeine does. And this is particularly because codeine is a morphine, is an opiate, so it's going to act centrally. So there is no place other than the cup center to say this is the mechanism of action. Just take it as codeine is an anti-cup. Now, as I told you, codeine, opiates, morphine, they have their analgesic effect, right? They have their centrally depressing effect. Now, what's interesting about codeine, and that's why it's reserved as an anti-cough medicine, rather than morphine being an anti-cough medicine, is that when you give it at lower doses, it's going to give you an antitussive effect without any analgesic effect. Now, can you explain that? Why does that happen? Because as I said, the analgesic effects are related to the conversion of codeine to morphine, right? While the antitussive effects are related to codeine itself acting directly on the cup center. So what happens is that when you give low doses, there will be no enough morphine levels within the body to produce the analgesic effect. Okay? That's why codeine at lower doses could be antitussive without any analgesic effects. Now, codeine is good as an antitussive because it's given orally. And we have several formulations of this oral drug. You can have it as pills, you can have it as syrup for children, you can have it also as capsules, whatever. And it could be also given via injection. But for the antitussive effect, you give it orally. Now, it used to be given for children, right? And not only for the antitussive effect, but it was also used as an analgesic drug. Now, there are studies that said, let me say, history-wise, doctors usually gave codeine after tonsillectomy, okay, or adenoidectomy to children as an analgesic drug. But what happens is that there were too many complications and actually death occurring after this clinical practice, so they stopped that. Now they just give the oral syrup with low doses just to produce the antitussive effect. Okay, so what would you expect the side effects of codeine? It's a centrally acting drug, so what do you expect? The first thing to expect is drowsiness, right? Particularly if you reach some pharmacological levels close to the analgesic effects of morphine, right? So drowsiness might be a side effect. The other thing, which is also opiate related, is constipation, because it's a side effect of opiates. And finally, the potential for addiction. Now, anything that's converted to morphine, of course, is going to have an addictive potential, but that's with abuse. And I don't know, it's something common in the society, in the community. People go by بدي دواء للجح, دواء ساعة, right? وبسلطنة. This is actually codeine, okay, or other derivatives of morphine. Because if you give it at higher doses, it's going to be converted more into morphine, so you're going to produce these euphoric and analgesic effects of the drug, okay? And that's why it has the potential for addiction. Nonetheless, it's still over-the-counter drug. And I don't know, at least in the States, is it here in Jordan? No? The tablets, okay. So what they did in the States is that they usually combine it with other drugs. Give me one example of a drug that's going to be good for common cold. People use it all the time over the counter. Paracetamol. And that's why you have this combination very commonly used, codeine plus paracetamol. Okay? This is the first drug. Easy. The second drug is something closely related, at least in the mechanism of action, which is dextromethorphan. Now, the difference between dextromethorphan and codeine is that this is a synthetic derivative of morphine. Okay? That was naturally occurring. And actually, codeine was metabolized and converted to morphine. Okay? As one of the end products of metabolism of codeine. With dextromethorphan, it's different, and the actions are also mediated by different kinds of receptors. Codeine acts on certain opioid receptors, while dextromethorphan usually acts through several other kinds of centrally located receptors. Okay, but the final action is suppression of the cough center and suppression of the signals coming from the periphery. So there is this sensitivity, there is this reflex coming through the efferent pathway. Just suppression of the central cough center. Now, because it does not, it's given via the oral route, okay, whether as a syrup or as pill. The good thing about dextromethorphan, as I said, it's not converted to morphine, it's converted to other products, so you would expect that the side effects would be much less, right? So safety-wise, it's better. What do you think about the potential for addiction? Less. And actually, historically, this drug was used to treat patients who are addicted to morphine. Okay? But still, we are human beings, and we are stupid. What happens next is that people started abusing the drug, and it started becoming a recreational drug. What do I mean by that? People just take it, and there is some effect of dextromethorphan if you take it for a chronic time, for a prolonged time, and with high doses, it might give you some sort of hallucinations. Okay? It's close to the action of mushroom. I don't know if you heard that in the movies. People take mushrooms to feel the hallucination effect. That's when you take dextromethorphan at high doses. Okay? In addition to that, it produces dysphoria, which is a bad thing, but people still like it. And it became an addictive potential for the drug. Okay? But generally, let's talk about, generally speaking, the normal guidelines for practice. Dextromethorphan is much safer than codeine. It produces less side effects, and there is less addictive potential. Okay? But I guess it's 2005. The American Thoracic Society did like a comparative study between the efficacy of codeine and dextromethorphan. And they found that there was no difference. Okay? But because dextromethorphan is much safer with less side effects, so much better compliance, clinicians like to use it instead of codeine as a first-line cough suppressor. Okay. Good. Any questions? Great. Done. Now we will start with our second lecture, and it's about the treatment of asthma. Now in your syllabus it says the treatment of asthma, but I added also the treatment of COPD as part of this lecture because we are dealing mostly with the same classes of pharmacological agents. Okay? As you're accustomed to me now, I always start with some background, anatomy, histology, and physiology to get things together before we start the pharmacological agents. Okay? Now, let's start from the scratch. And I guess you've seen that. This is an airway, and it comprises three layers, right? The first one, or the innermost, is mucosa. The second layer is submucosa, and the third layer is the medium, which is composed of smooth muscle. Now, if we want to look at it in a different angle and look all through the layers, we start with the epithelium, right? And this epithelium might be pseudostratified, might be stratified. At certain points, it becomes ciliated, right? Now, the second layer, or let's say that the epithelial layer, is always tethered, right? Tethered or fixed to a basement membrane. And the basement membrane is always a sign of normal structure. If you don't find the basement membrane, then there is something wrong, okay? So it tethers the epithelium and separates it from the submucosa, which is, as you know, is a connective tissue. So you would find fibers, different kinds of fibers, including collagen. The other thing that you might find within the connective tissue is blood, or blood vessels, right? And the third thing, which is important also, are the mucus glands within the submucosa. The mucus glands function is also supported by some kind of cells interspersed between the epithelial cells, as you can see here. And these are the goblet cells. Now, what's the function of both mucus glands and goblet cells? It's mucus secretion. Now, you have a full physiological function of mucus next to cilia. Cilia just moves, and it leads to the movement of mucus. Once there's a pathogen or whatever, it's just trapped within the mucus, and because of the movement of the cilia, it's expelled outside. Right? Now, what's going to come down below the submucosa? It's the airway smooth muscle cells. Okay. Now, just to remind you about the function of smooth muscle cells, the bronchial smooth muscle cells. They are different from vascular smooth muscle cells. As you know, that we always have the calcium channels. The intracellular calcium concentration is very important for contraction. What's the other factor important for contraction? The myosin light chain, phosphorylation. Okay? So once both of these are present, there will be contraction. Now, this is mediated mainly by the parasympathetic M3 receptor. Once these are active, what's going to happen? Increase in intracellular calcium concentrations, entry through the channel, and phosphorylation of the myosin light chain. Then that's going to lead to contraction. Now, the opposite of that is the function of the sympathetic system mediated through the beta 2 receptor. Okay? Now, the function is mainly, again, it's opposing the parasympathetic, so it's going to inhibit both intracellular or the calcium entry and the phosphorylation of myosin light chain. That's going to lead to relaxation. Okay? This is important when we discuss pharmacology. Now, the two diseases we are dealing with today are bronchial asthma, right, and COPD, which clinically is divided or segregated into two kinds of conditions, or two conditions: chronic bronchitis and emphysema. Have you discussed these two? No? Okay. So I guess you will have a pathology lecture and a clinical lecture about the COPD disease and asthma, but basically these diseases are always classified together in internal medicine books. Why? Because they share something called the obstructive lung disease. Now, the obstructive lung disease, I'm going to show you some histological features and pathological features, but how do we assess that clinically?
Spirometry test.
Exactly, it's the spirometry, and I guess you will also discuss that in the clinical lecture. What's the difference between obstructive and restrictive lung disease? Okay, now basically what I care about is that asthma, chronic bronchitis, emphysema are considered as obstructive lung disease, and the therapeutic options are usually the same. Now, what are you going to see pathologically or histologically in obstructive lung disease? This is the normal lung, and this is a normal looking alveolar unit with the terminal bronchioles, and you see how patent they are. The small muscles are not very tight, they're not hypertrophied, everything looks normal, and the airways are clear for a good gas exchange function. The opposite of that is what happens with obstructive lung disease, both asthma and COPD. You're going to see certain features included in this. The first one is bronchoconstriction. And just imagine, what's the major factor for this bronchoconstriction from what I said about physiology? The parasympathetic activity is the major factor for this bronchoconstriction, plus other factors we're going to discuss in a minute. The second thing is, as you can see, the luminal narrowing. Okay? So there is constriction, and there's a lot of other factors that will contribute to the luminal narrowing, which I will discuss in a minute. And the third thing, what do you also notice? Exactly. There is the mucus hypersecretion. All of these together are going to lead to what? What's going to happen to airflow? Exactly. The airflow is decreased, and that's why we call it obstructive head. Right? Because the airflow to the lung is decreased because of all these things. Now, looking from above, this is okay. But if you want to target something, to treat something, you need to look from down, right? To see what's the basic or the major leading factor for all these changes. And as, if you remember from our lecture last term, I told you that the devil for both kinds of diseases, COPD or asthma, is the chronic airway inflammation. Now, normally you wouldn't see all these inflammatory cells infiltrating the airway, right? This is going to be a clear state. Now, chronic airway inflammation will lead to something called airway structural remodeling, which the net result of this airway structural remodeling is airflow limitation and the obstructive lung disease. Now, what do I mean by airway structural remodeling? Again, let's go back to the normal histological structure I showed you. What's the first sign of pathology in this histology? Exactly. Always go and look for the basement membrane, because it's one of the first signs of pathology within the lungs, within also the kidney. The basement membrane is very important functionally. So the first thing that happens, or one of the first signs of pathology within the airway histology, is the absence of basement membrane or the digestion of basement membrane by certain enzymes. The second thing that's going to happen also is the smooth muscle hyperplasia. Okay? Small muscles always start with hypertrophy to respond to stresses, but later on they start increasing in number, and that's when we call it hyperplasia. What's better, hypertrophy or hyperplasia? Exactly. Hypertrophy is a much better adaptation mechanism of small muscle cells, because once the stress is out, the cell will come back to its normal size. But because hyperplasia means proliferation of cells, how are you going to get rid of all these extra or additional cells? Okay? And that's why pathology in obstructive lung disease is hard to treat and hard to cure, because we have certain irreversible things. We have extra layers of small muscle. How are you going to kill these? Right? Now, the third thing that's going to happen is the goblet cell hyperplasia and the increased mucus. Both of these will lead to what? The mucus hypersecretion. Okay? So as you can see, this unit, which was like of this limit, of these dimensions, become just much, much bigger. Right? And all that is the cause of luminal narrowing. Instead of being like this of dimensions, it's increased to like this. So there will be no airflow within the airways. Now, finally, which is important also, is the increase in the number of blood vessels and the increase of the blood flow within the submucosa, which leads to wall edema. Okay? All these are considered airway structural remodeling, contribute to airflow limitation. So instead of an airway looking as painted and as beautiful as this, it becomes just like that. And that means much less air coming down to the lungs. Okay? Does that make sense? Okay. Now, what are the major contributing factors for the pathology of obstructive lungs? Well, for asthma, as you know, atopy or allergic reactions are, or exaggerated allergic reactions are the basic and most contributing factor for the pathology. And that's why you always encounter house dust mite and pollens in the treatment or management of asthma. Okay, because they are one major contributing factor for asthma. Now, with regards to COPD, particularly chronic bronchitis, smoking is involved in almost 90% of patients. Okay? And what they found, like in a prolonged cohort study, that chronic smokers, almost about 60 to 70% of them will end up having chronic bronchitis. Okay? Which is not that pleasant. I'm a smoker. Okay. Now, what do you expect the clinical picture will be? Just give it a guess. What are the symptoms you might have if you have asthma or chronic bronchitis? Okay, good. Dyspnea or shortness of breath. There's airflow limitation, less air coming down to the lungs, then there's this. What else? What? Okay. It's not something characteristic. I need something related to this pathology. Wheezing, exactly. There's airflow limitation and luminal narrowing, so the air, when it comes in or comes out, it's going to produce a sound, right? A noise. Okay? This is wheeze. What else? Always, as I said, if you have too much stuff plugged into your airways, then the cough reflex will be activated, right? So cough is one also characteristic symptom and sign of obstructive lung disease. Okay, so the clinical picture is usually a triad of things: cough, wheezing, and dyspnea. Okay, coupled with chest tightness. Do they have chest pain? Yes, there's no need, or there's no explanation for chest pain in these patients. It's all related to the breathing process. Okay. Treatment. So, if you understood what we talk about, the pathology, it's always easy to guess the pharmacology, right? And that's what I'm trying to transmit to you, to convince you that studying pharmacology is much, much easier than you would expect. It's not about memorizing stuff, memorizing too many words and too many pages and getting into the exam and forgetting everything afterwards. It's simple. If you understand pathology, link it to anatomy, histology, then the pharmacology will be much, much easily attainable. Okay? So, going back to the pathological processes we discussed before, the first thing is you need to remember, what's the major pathology? It's this. An airway looking as badly constricted and narrowed as this. What do I want first? Make it bigger. Okay? What do we call this process? Something small making it bigger. Bronchodilation. Exactly. So the first thing to do is try to broncho or to dilate the airways. Now, I told you there are two major factors contributing or regulating the constriction, relaxation of airway small muscles. Parasympathetic leading to contraction, sympathetic leading to relaxation. So if I want to bronchodilate, what should I give? anticholinergics or beta-2 agonists. Exactly. So the basic concept or the basic agents involved in the bronchodilation are the beta-2 adrenergic agonists and the anticholinergics. Now there is another family of drugs that could be used to achieve such function, which is the methylxanthine, but through a different mechanism. By the way, the handout I gave you yesterday, it's not for exam sake. So do not go and study and memorize and all that stuff. I just gave it to you for like a reference. Just look it over. If you need any referencing for any idea we mentioned in the lecture, you're going to find it there. Okay? So don't be scared. Okay, so this is the first thing to do, bronchodilation. What else? What's the next step in the management?
Prevent chronic inflammation. Chronic inflammation.
No. Okay, someone said inflammation. Always try to look for the major cause for symptoms, and then try to look for the major pathological process. And as I said, the devil in this kind of disease is chronic inflammation. So the next step in the management is trying to inhibit inflammation and the structural airway remodeling. This is achieved mainly by corticosteroids. Always, you hear inflammation, couple that to corticosteroids. Right? Now, if we go further down into the pathology, as I'm going to discuss in a few minutes, then we're going to find that another major player or mediator of inflammation within the airways are leukotrienes. So when these are produced, there is much more inflammation, there is much more remodeling. So the next pharmacological option is inhibit that. Just get rid of leukotrienes or the leukotriene function. Okay, this is what we discussed in the previous last term. But this time I wanted to add two more classes of drugs because you are much more mature. And these are the mast cell stabilizer. And we're going to couple that what we discussed yesterday about the mast cell, the function and the dysfunction. Okay? And you're going to, I hope you will understand why it's considered one of the agents for the treatment of asthma. And finally, the anti-IgE. Okay? You're going to understand that in a minute. Okay. So, as you could see here, what I labeled this kind of drugs, long-term controllers. What do I mean by that?
For life.
Okay.
No, not for acute cases.
Exactly. What we deal with in the long-term controllers is something to act on the major pathology, the major causative pathological processes for the disease. Okay? So the action is usually something that will take a long time, and the benefits over the long run would be much more than the symptomatic levers found in the bronchodilator's limb or group. Okay? So if you have an acute emergency condition, you always look for the bronchodilator's limb. But if you want to maintain your patient on something, then you always look at the long-term controller's limb. Okay? Just as we discussed when we talked about the ischemic heart disease, if we are talking about an acute phase, something that will reduce the mortality acutely, then aspirin would be one drug. While if we want as a long-term control thing, then statins, for example, would be on that limb, right? Because the function is to reduce cholesterol and LDL and reduce the atherosclerotic pathway. Okay, so that's why we call the bronchodilators as symptomatic relievers, and emergency doctors always know these things. Okay, we have 10 minutes, so we will try to finish the first two classes, and in the second lecture we will finish with that. For the smokers to smoke. Okay, starting with the beta-2 adrenergic agonists. If you remember that what we have clinically right now are two classes of beta-2 adrenergic agonists. The first one are called short-acting. And in all literature and clinical books, you're going to find it as SABA. And most patients will know it as SABA, in the West. Okay? It's short-acting beta agonist. And the two common examples of these drugs are salbutamol and terbutaline. And if you remember before, I told you the public know this kind of drugs as البخاخ الأسود. Right? It's mostly the short-acting beta-2 agonist, and we're going to know, or we will know in a minute, why it's so commonly known to the public. Okay? Now, the short-acting beta-2 agonists are called this way because there is an immediate or up to 10 minutes of an onset of action. So once the patient takes the puff, supposedly in the right way, okay, the effect will be felt immediately or up to 10 minutes. And that's why it's taken as symptomatic relief. Okay? Now, the other thing that plays a role here is that the duration of action is 4 to 6 hours. Okay? So you would expect that with the long-acting, the onset of action would be slower, and the duration of action would be longer. Okay? Now, it's important to get to the point to know that short-acting or SABA are the quick relievers. And that's why these are considered the asthmatic patient best friend. Right? Every asthmatic patient has this Bakhaf Azar in his pocket. Okay? And they know that whenever I have symptoms, or whenever I expect to have symptoms, then having a puff, 2 or 3, is going to be good because it's going to relieve my symptoms. Okay? Now, the clinical comments, the thing that we like. The first thing is that they are the first line quick relievers in both asthma and COPD. I mean, just look at it. There's an immediate action, it's going to last for 4 to 6 hours, it's going to relieve the symptoms. What's better? Right? So that's why it's always the first line quick reliever. The second thing is that a lot of patients use it prophylactically prior to stimuli. Like if a patient is going to exercise or is going to a place that might have some allergic conditions. Okay? People who have occupational asthma, like asthma related to the workplace. Then they take some puffs prior to getting into that stimulus. Now, a lot of people thought, okay, if it's that good, if it produces these effects, then why not regularly schedule the dose? Like tell your patient, take 10 puffs a day, 3 with each meal. Right? Why not? It's good, and it lasts for 4 to 6 hours. Okay, so basically what they did as a clinical trial, there was no benefit at all. Okay? This is first. Second thing, what they found is if you are using the beta-2 agonist frequently within the day, then that means what? Then that means that your disease is getting worse and you're having a more severe condition. Okay? That's why regularly scheduled doses of the short-acting beta-2 agonist is not recommended. There is no benefit, there is less efficacy, and another thing, it's a sign of getting a more severe condition. Okay, these are some. Now, love, the long-acting beta-2 agonists. Okay? We have two common examples in practice, salmeterol and formoterol. Okay? Now, as I told you, the difference would be from SABA, slower onset of action and longer duration. action. The onset is 15 to 30 minutes instead of being an immediate effect. And the good thing about it is that it lasts for up to 12 hours. So, what are the pros and cons of this drug compared to some? I mean, advantages and disadvantages compared to skin. Let's start with advantages. Exactly. Less frequent, okay? And which means more compliance from the patient, right? Now, disadvantages of this.
Does not reflect severity.
Okay. Which means what? Exactly. We cannot use the long-acting beta-2 agonists as quick relievers or symptomatic relievers. Okay? And patients actually do not take the salmeterol inhaler with them all the time. Right? Because their doctors tell them that you're not going to feel the effect quickly, and although it's going to last for a much longer time. So they're not considered quick relief. Now, what they found is that actually the LABA or the beta-2 adrenergic agonists could be considered part of the long-term controllers, okay, or symptom controllers, and I will show you why. Practical comments. First, since it's not a symptomatic relief, right? It's not a quick relief. Does it target the pathology of asthma or COPD? No, right? It does not target inflammation. It does not target airway remodeling, right? So can we consider it as a long-term controller or something to inhibit the pathology? No. So can patients take it alone without any other drugs? No, right? Because an asthma patient, it's either mild, intermittent, so they need only the quick relievers, the beta-2 agonists, the short-acting, or it's a more severe condition that they need what? They need something to target the pathology. And that's why when we add other classes like corticosteroids. LABA is something in between. It does not get this function or that function. It's not a quick reliever. It's not something to target the pathology. So that's why in 2010, the American Heart Association published and said that it's contraindicated to be given alone. Okay? The second thing is, as I said, it's not going to be used or prescribed for symptomatic relief. And what about during exacerbation? A patient, an asthmatic patient came to the ER. Should I give him LABA? No. But, so what's the point? Why are we giving you this drug? Because what they found is that if you give LABA plus the inhaled corticosteroids, it's a very good regimen for the treatment of persistent, whether mild or moderate, persistent asthma. So what it achieves is a function combined with steroids. It's going to reduce the dose of steroids needed for the management, and plus that, it's going to be good for symptomatic relief over a longer duration of time. Okay. What's the major side effect we will be afraid with the beta-2 agonists? Okay. Your colleague said tachycardia. Now, that's fair enough, right? But as I said, these are beta-2 agonists. So would you expect them to have tachycardia? Now, basically, theoretically speaking, no, because the tachycardia is derived from beta-1. Now, a prolonged use, much more frequent doses might have certain effects related to the heart, related to the liver, which might be tachycardia. But with the inhaled route, most of these symptoms are not there. Okay? Most of these side effects are not there. What I care about is something you will find in practice, something you will find in your patients. Patients will come complain about. And it's only one thing, with the beta-2 agonist, and it's tremor. And you will notice that books call it the skeletal muscle tremor. Okay? Because it's not something neurogenic. Okay? It's something related to the function or the effect of the beta-2 agonist on skeletal muscle. The accumulation of that in the skeletal muscle will lead to skeletal muscle tremor. Now, is it okay or not? I mean, is it bad or not, tremor? Now, some patients might just accept it and live with it, right? But some other patients might not tolerate it. Okay? So in that case, what are you going to do?
Reduce those.
We're talking about SALT. As I told you, it's the patient's best friend. And he's complaining of tremor, and he says, no, I cannot live with that.
Decrease those.
Take it away? You cannot take it away, right? Because it's integral to the therapy. It's the first line as a quick relief. So you have to introduce a new kind of bronchodilator that could be used as a quick relief. What do you expect that would be?
Reversing.
Anticholinergics, and that's what we're going to discuss after the break. Okay? Take a 5-minute break, please. 10 minutes break, and then we'll
بالضبط التوكيل ده مزمت يعني اديني العده يا معلم شو بدك عمر؟ اسمع اذا بتحكي شيء عن التسجيل بخبط الموبايل براسك
كل هذا اسمع كل هذا تسجل على فكرة. كل هذا تسجل ولسه هذا بتسجل